Hello, Gary. Welcome to the discussion regarding men's health today. My name is Kudzai Nyamande. I work in education. I work in mental health, and I'll be talking to Professor Gary Wittert from the University of Adelaide. Do you want to introduce yourself,
So
Gary?
thank you, Kudzai, and thank you very much for having me on the podcast and allowing me to share some of my thought. I'm Gary Wittert. I'm a professor of medicine at the University of Adelaide. My medical specialty is endocrinology, so I help take care of people with diabetes and disorders of the endocrine system. That includes things like reproduction, various metabolic disorders, obesity, and I have a particular interest in men's health and head the center, a center for men's health research. It's called the Freemasons Center for Male Health and Wellbeing, and that's based at SAMRI.
Thanks a lot, Gary. My first question, Gary, is that there seems to be this, whether to call it a myth, that men neglect their mental health, that men neglect their physical health, but that they don't prioritize their health. Is it something that you subscribe to, or you've got a different view about that?
I don't think that men intentionally neglect their health. Men are interested in their health. And one of the things about is that men care for their families, their wives and their children, and they care about their jobs and they care about their communities. And so they are providers and they are protective. And in order to do that, you have to take care of yourself. And I think men intrinsically know that. But I don't think that for many men, particularly men who come from countries where there may not be healthcare that's organized in the way it is in Australia that provides preventative health services, they may not realize what sort of things should prompt them to visit a doctor. And also, we've found from some of the research we've done that when men have something wrong with them, they're not familiar with what it is, then they tend to self-monitor. They hold back and they watch and see how it goes. If you get a strange noise in the car, then you might have a tinker. And that's different to if you know what the problem is, then you can take very targeted action. If men know that there's something that needs to be done, I think they're very action-orientated and they'll do what needs to be done. The problem comes where there's uncertainty or there isn't knowledge about it, what we would call health literacy, understanding about health and about how things present in terms of different conditions and what should be checked and when it should be checked. And one additional aspect to this is that some of these disorders present differently in men and women, and that adds to the complexity.
What kind of prompts do you think men should not ignore with regard to their health?
I think the first thing is everybody needs a routine check. There are many things that we have that lead to the possibility of not being healthy, particularly as we get older. And so if we don't have those conditions detected early, then by the time they are detected, it's because they've caused a serious problem. So let me give you an example of high blood pressure. If you get regular checks and the doctor finds that you've got elevated blood pressure and it's explained to you what the nature of the problem is and you get appropriate treatment and the blood pressure is controlled, that need not cause you any further problem. But if your first presentation because of high blood pressure is into a hospital with cardiac disease or into hospital with a stroke or some kind of hypertensive crisis where you can get very high blood pressure with brain swelling, that is a failure to prevent serious harm. And we don't think if that happens, it's because men don't care. It's rather because they didn't know that those checks needed to be undertaken. And I think for men in Australia, there's been more education and their wives send them along. And so those conditions get detected. Whether your blood sugar's abnormal or whether there's a cholesterol problem, and there are many other things that can be found that can be corrected or improved, avoiding emergency admission to a hospital with a catastrophic event.
All right. There's also another myth that men neglect their mental health and they only come at crisis point. Is this something that is your experience?
It is true that very often the first presentation is at a point of crisis, but that doesn't mean men haven't sought help before, or that men have been deliberately neglectful. And so the sort of thing that you see, firstly, is that when men are in distress, they may not understand what's going on. They may interpret the problem as a physical problem. They may interpret the problem as fatigue. Fatigue is a symptom of depression, and we attribute fatigue to many things. I'm stressed, I've got too much to do, my wife's annoying me, I don't get enough sleep, and so on. Many people don't understand that irritability and aggression is a feature of depression in men, that excess alcohol consumption or the need to drink on a regular basis alcohol could be a symptom of depression in men. Sexual dysfunction could be a symptom of depression in men. Sleeping too much or having difficulty getting to sleep could be a problem. If we don't understand what's happening to us, then we may, as we talked about previously, we may self-monitor and see what's happening. We may be confused and not know where to get help or who to ask or who to talk to because there's stigma around mental health. People may not want to raise the problem as being related to mental health, and so it gets pushed to some physical problem. And very often men have been to seek help, but they haven't directly indicated that I'm here with a mental health problem. And they may have presented with physical symptoms, and mental illness in men present very differently to women. We know from research we've done and also research that comes from 10 to Men that only 40 or 50% of men who present for care when they've got a mental health condition get recognized as having a problem and treated or referred on for more specialized care. And one of the interesting things we found is that men with a high burden of symptoms of depression actually see their general practitioner far more frequently than all other men.
That's a very interesting perspective there, which kind of goes against what is accepted in the community, that men don't really seek help at all.
Absolutely. I think that's quite incorrect that men don't seek help. Men do seek help, and they seek help frequently. Now, I'm not talking about men from CALD communities where there may be a different understanding. Just on the average, all other things equal, Australian men with equal understanding and opportunity to access healthcare.
All right. Yeah. Because coming from a CALD background, I remember when I was young, we were told men don't cry. Trying to express feelings of sadness was not accepted then. So you brought this aspect of men from CALD background. So it could be that there might be a different maybe perspective or a narrative there, especially for those target group.
The issue of men don't cry is something that's commonly brought into the narrative as being around how boys are taught and how boys are masculinized. Putting that aside for a minute, masculinity can be tapped into in a strength-based way. If men have been told not to cry, or men have been told not to show distress, doesn't mean they don't show it in some way. And so I think it's really important that we as a profession take a strength-based approach to masculinity. How we socialize young men and boys is a separate issue. And I don't think that should in any way disadvantage those men who have particular attitudes, and they're not going to change them. We can't just tell them to talk differently or talk more openly because that's not the way they are. It's quite reasonable to teach boys and young men to be more open about their feelings. It's okay to cry. It's okay to express emotion in a range of ways and talk about it. That's fine. And I think that will produce very good outcomes. But I still think that at the end of the day, there's a certain biological thing about being male that will confer certain behaviors, like it or not.
About 3 weeks ago, I attended an event, a breakthrough event at the Oval Center. And I think there were more than 800 men. So they got us to go into the Oval. And they were asking these questions. So they were asking, who has cried in the past week? And the men who have cried were asked to walk one step forward. And it was amazing that almost all men who managed to step did confide that they were crying over the week. And they went on to ask who has cried in the past 3 days. I think 99% of the men did confide.
So what does that tell you? It tells me that the narrative is just nonsense. And where does this narrative come from? Because it pervades the literature like a bad smell, in my opinion. And when you ask, where is the evidence for this? It's just not there. The conversation around masculinity comes from gender politics. It doesn't come from a health paradigm. It's been adopted into a health paradigm. And I know of no intervention, and I'll say this guardedly, that says that if we address the issue of masculinity, we get better outcomes. We don't tell women not to be women. Why are we telling men not to be men? I just think it's a travesty. And the notion of labeling men as having toxic masculinity effectively is saying these are bad men, ignoring the fact that there may be a mental health disorder. Because in men, mental health disorders is driving high-risk behavior, it's driving substance abuse, it's driving aggressive and irritable behavior. We have this problem where people coming out of the social sciences are constructing this belief system that certainly doesn't accord with what I see in practice, and it doesn't accord with my interrogation of the data. And it doesn't accord, by the way, with what you've just told me.
Definitely. There is this notion that maybe African men are strong and they withstand a lot of challenges. And so it's accepted statement.
Who says that?
Whether it's the media or people just said it, but it's not
true
supported
at all.
by...
African men are no different to any other men. They're the same as all other men. And to say that they're more stoic, I know no basis for that. You're an African man, you're a proud Bantu man. What evidence is there in your view of that?
There is no evidence, but it seems like it's somewhere. It just comes from, I don't know whether it's perpetuated by the media or what. And you know what? Still on those African men, the evidence out there doesn't support that.
No.
There's quite an increasing suicide rate in African men. There is a lot of... It's not supported by evidence at all.
No, absolutely. It's just an outrageous proposition. And it fundamentally says that we don't understand the people we're talking about. And people are people. It doesn't matter where you find them. They may have some cultural nuances. They may have some different belief systems. They may be educated a bit differently. But at the end of the day, when you sit down and you have a conversation with someone, it's just two people, they're the same.
All right. That brings to this issue of maybe normalizing a conversation around mental health. How do you think we can go about normalizing those discussions so that the people seek help and people are not stigmatized?
You normalize a discussion by starting off with sharing information. Stepping aside from mental health for a moment, disorders like obesity and diabetes come with the implicit association of behavioral disorders. You were too lazy, you lack control for what you eat, it's your fault. There is stigmatization around many different conditions. Men don't normally sit down and talk about their health with each other. Women are much more likely to discuss issues. People with obesity are much less likely to discuss that as a problem. But if you raise it with someone in an open and non-judgmental manner, people will talk to you about it. So I think taking that as the example, if people understand what the nature of this disorder is, that it's not someone's fault, that they don't choose to be like that they're not inherently lazy, and that they're not inherently bad people, immediately changes the conversation. But that's something that you have to build into people's thinking from very early on.
And I always give this example of diabetes. People with mental illness are stigmatized. And maybe what you have said about trying to normalize that maybe might go a long way into people eventually accepting that maybe depression is caused by maybe the serotonin levels not being that issue of chemical balance, and which is maybe can be in a similar way what is causing someone with diabetes his body not to produce the right amounts of...
I think the chemical balance theory of depression is probably questionable. Why can't depression be an inflammatory disease, for example? People, when they get flu or COVID, can get terribly depressed. And there are many autoimmune or inflammatory disorders where depression's very strongly part of that. Depression in obesity is probably related to a degree of inflammation. There's a very strong relationship between lower urinary tract symptoms and depression and obstructive sleep apnea where there's inflammation. When we look at conditions like depression, we have to think about what are the circumstances that this person is in, because we respond to our environment, and the part of our body that responds most to the environment is the brain, because that's what's interacting. So stresses and those kind of concerns and how we adapt to challenge is all an important aspect of it. Physical activity is extremely important for positive mental health. The diet that we eat and sleep, absolutely critical. So someone who's not sleeping, who's not eating well, and who has very difficult social circumstances is going to be more susceptible to depression. And also there's some imprinting that occurs. People who were survivors of the Holocaust pass on psychological vulnerabilities to their offspring and they to their offspring, so that there's this transgenerational thing. And many migrants to Australia come as refugees from horrible circumstances. And so much the same will apply. There's a certain inherent vulnerability that's going to affect them and that potentially will affect another generation. I think it would be wrong of us to make this sound simple. We have to think about it in the context of the individual and the individual's function in relation to their families and broader society. And the key thing is to understand that just because the disorder is in the mind and affects behavior, it's no less of a disease process than if the problem was in the appendix and caused pain, and there the solution is simple and you can take it out and there's a cure. Here we deal with something a little bit more variable and complex with many different intersecting causes. But to argue that people want to be like that, I think you're crazy. People talk about it openly. If our role models are talking about it, and we see football stars coming out and media personalities coming out and talking about their mental health, and that shifts the conversation, because that tells other men, wow, I'm not special. Other people share this problem and it's common. And so that's the kind of thing I think that drives the conversation. I think that kind of thing makes a big difference.
While you're saying that, I remember during the time of HIV epidemic, when it started, there was a lot of stigma around it. And I remember, I think I was in Africa then, the government devoted quite a lot of money in education and awareness. Because I remember people used to spread rumors, or it spread through it sharing food and all that. But that awareness helped so much. It had so much profound results. And people with HIV, and even now, you go there in community, people no longer talk about it. It's accepted and people just get on with it.
And that's the classic example. To destigmatize something, you have to demystify it and understand what it is. And I think that part of the problem is that if we don't have a spiritual as well as a physical approach to disease, you're in Africa and you have distress, you have a mechanism to understand that distress, and you have acceptance of that distress, because everyone accepts that when you have distress, you go and see a witch doctor or Sangoma or something, and they will talk about the spirits and who has to be appeased and who's done this to me. And so there's a spiritual healing that takes place, but there's also an acceptance to a certain extent of the symptomatology when it's not physically based.
Oh, crucial point. Crucial. I know earlier on you mentioned about the issue of the body being functioning. It's not only about one part, it's about the sleep, it's about what you eat, and it's about, so not to look at it at the whole body. The issue of diet that you brought about, there is increasing like cancers coming up in quite a lot of the CALD population. And in the past, we used to eat an almost entirely vegetarian diet, but I think now we are eating a lot of meat. And growing up, I know people used to say, I'm not a rabbit, I won't eat vegetables. So they just eat meat. And I was around during that time when things shifted. from a vegetarian diet to
Well,
to
why
a
would
meat diet. I'm not sure what caused that, whether people started to get more money and maybe vegetables were associated with inferiority, the fact that you don't have any money, vegetables were cheap. So then the diet kind of changed dramatically from a vegetable diet to a meat diet. And I think it has coincided with an increase in cancer. Is there a link there in diet, or what, from your experience?
Yeah, diet's very strongly linked to cancer. And there's a relationship between eating a lot of meat and bowel cancer. The vegetable diet is protective. You need the fiber and possibly other components of a vegetable diet that confer protection. Physical activity is protective, and alcohol is a very strong risk factor.
Right. Oh, and also the increase in alcohol as well as
Yeah.
the
And
meat, quite an
also
increase.
how the meat is cooked. So if the meat is charred, burnt meat increases the risk of cancer. And if meat is processed, the nitrate is cancer causing. Meat's part of a healthy diet, but too much meat, particularly charred meat and processed meat, are associated with increased risk.
All right. So if you are to talk to maybe someone from an CALD or an African background, what kind of diet would you recommend
I think the same,
for
I
optimum
recommend,
health?
yeah, I think there's this notion of dietary monotheism, one diet, one God for everybody kind of thing. And there's a uniformity about what constitutes a healthy diet. And the answer is fresh whole foods, not too much, mostly plants. And I think that remains true and it remains universal.
Right. Okay. Oh, thanks a lot. I think we've covered quite a bit of information today.
We have.
Before we go, any last word?
Yeah, I think that in accordance with strengths-based approach, men who've migrated need to accept that they have enormous strength to come through the circumstances that they have, to make the move to migrate, to establish a life and build a foundation for their family, and that there are always going to be challenges that affect mental health. And I don't think that should be viewed by men as a weakness. When men migrate, they have to learn about the banking system. They have to learn about the laws of the country, how things operate, language, if that's the case, and learning about health, if they've never learned about health and how to maintain good health, is just another element of that unfortunately we often ignore. And I think having a push to deal with that better is very welcome. So thank you.
All right. Okay. Thanks a lot, Gary.